Good morning, everyone. Welcome to Mass General Brigham Global Health Grand Rounds. I'm Louise Ivers. It's my pleasure to introduce our speaker today, Dr. Molly Franke. Dr. Franke is an associate professor of global health and social medicine at Harvard Medical School. She's a global health researcher who works to bring her expertise in epidemiology to address infectious diseases. And she also specializes in using epidemiological methods to address diseases of impoverished and socially marginalized people using the highest quality of evidence through her epi methods. We're delighted to have her speak to us today about building a research agenda to strengthen care delivery for youth living with HIV in Peru. I'll encourage everyone who might have questions to use the Q&A feature in the Zoom, and we hope to have time at the end of the presentation to ask Dr. Franke some questions and to bring your questions to her. Thanks very much. So I'll hand it to you, Dr. Franke. Thank you.
Thanks so much, Dr. Ivers, for the invitation and introduction. It's an honor to be here to share some of our team's experiences building a research agenda with the overall aim of supporting adolescents and young people living with HIV in Peru. I have no conflicts of interest, and research funding from the US National Institutes of Health and Harvard University supported this work. I first just want to start by acknowledging the talented team of people who have contributed to this work. As an epidemiologist, I consider my role as a documenter and a cruise director of sorts, with really the true innovation and incredibly empathic care delivery coming from the team of providers at Socios and Salud, the Peru branch of Partners in Health, as well as from our collaborators at the Peru National HIV Program. It's really been one of the greatest privileges of my professional life to partner with them in this work. So in this talk, I'll provide a brief background on adolescent HIV, highlighting some of the research and service delivery gaps, particularly for Latin America. I'll then spend most of my time describing the evolution of our work in this area over the last 9 years and describe some of the challenges encountered and lessons learned along the way. I want to start just by providing some numbers for orientation. I know many of you are probably familiar with them, but there are 1.75 million adolescents 10 to 19 years old living with HIV, and 150,000 new infections in this group annually, and 30,000 or 32,000 deaths. ART coverage overall in this group is suboptimal at around 54%. And relative to older and younger people, adolescents living with HIV on average tend to have worse adherence and higher rates of losses to follow-up. And this is due to a host of factors that converge during this life stage. So among them are the lack of a fully developed frontal cortex to aid decision-making at a time in life when adolescents are actually expected to be assuming increasing independence for their own health and self-care. And in the context of perinatal HIV infection, this can be further exacerbated by cognitive deficits in processing speed and various aspects of executive functioning. There are also, of course, profound social and biological changes during adolescence that can be incredibly complicated to navigate, even in the absence of a stigmatizing chronic condition. And adolescents' natural tendency to prioritize peer relationships and keep their diagnosis a secret can interfere with antiretroviral adherence. Mental health is another incredibly important factor. The rapid brain development that occurs during adolescence may leave it especially vulnerable to stressful or negative life experiences. And so the extent to which HIV in adolescence is a marker of other social risks, it's not surprising that the percentage of adolescents with a history of trauma or psychological distress is elevated in this group. There have been a couple of meta-analyses published in the last couple years that suggest that up to 25% of adolescents living with HIV are experiencing depression, with up to 50% showing emotional and/or behavioral difficulties, with lack of family support and poverty being exacerbating factors. And this is just, I think, a great illustrative quote from one of the adolescents that we've worked with. the interviewer asked her why she was not taking her medicines, and she said, "Because I'm going out with my friends." So I think another consideration is that adolescents living with HIV are often at risk of missing the building blocks necessary to maintain overall health. So this is a slide from WHO that shows the basic components of adolescent health, and arguably they're even more important for adolescents that are living with a chronic condition. So you can see the first item on there is families, and we know that many adolescents living with HIV, especially those who were infected at birth, lack family support. So in Peru, we estimate that more than a quarter of adolescents infected during early childhood have lost both parents. And newly diagnosed adolescents in Peru may often lack this support due to fear of disclosure or due to family estrangement related to their sexual or gender identity. If you move on to the second block there, healthcare, in many healthcare settings, health providers do not receive special training in adolescent health. They may not feel prepared to talk to a teen with HIV who is struggling with their sexuality or wondering if they can have a family. In addition, health professionals may have limited time with each patient, and facilities may have limited resources to invest in making their environments adolescent-friendly. So if we look at that fourth block, clean air, water, and sewage, I would just add food security to this list. We know that when basic needs cannot be met, it's difficult to talk about good treatment adherence. Next, transport systems. So transport systems must not only be safe, but also affordable and accessible. So this is especially important in places where ART is not decentralized and requires sometimes long trips that adolescents may need to make alone. And finally, that last block, in many places, the laws do not support the health of adolescents. So for example, in Peru, minors cannot access family planning services or condoms through their healthcare provider without parental permission. And so policies like this can provoke behaviors that put both the individual at risk or in unsafe or undesirable situations. And so for me, I think the bottom line is that from an equity perspective, adolescents living with HIV need and deserve more support, not less. But this is often not the case, despite the fact that supporting these adolescents has huge potential to pay dividends, not only in terms of protecting their own health, but also in terms of preventing secondary transmission to partners and the health of their future children. We know that health is something that can be transmitted from intergenerationally. So the research community actually has been relatively slow to respond with evidence-based guidance for best practices with regard to behavioral interventions for adolescents living with HIV. So here are just a couple of quotes from recent review articles. Most conclude by highlighting the absence of data and evidence-based studies, particularly outside of the US and Europe. And this scenario, thankfully, has changed quite a bit over the last 5 years with increasing data emerging from sub-Saharan Africa. However, data from other parts of the world remain quite sparse. So this is a document from a few years ago. The WHO, International AIDS Society, and their CIPHER grants program undertook a project to engage global stakeholders to identify research priorities for adolescents living with HIV, and their service delivery interventions that they identified included to improve retention and care, support pregnant adolescents living with HIV, improve sexual and reproductive health, and to offer social support. And they also highlighted the critical need for interventions to be tailored to the local context and to specific risk groups. And I think the importance of tailoring interventions becomes very clear when you consider the varying epidemiology of HIV across settings. In contrast to sub-Saharan Africa, which has a generalized epidemic that disproportionately affects young women, Latin American countries tend to have concentrated epidemics, which primarily affect sexual and gender minorities and health workers. So as the need for evidence-based interventions for adolescents living with HIV has grown in recent years, there's been growing recognition that any intervention must be tailored to the specific life phase, or in other words, it must be adolescent-friendly. And the WHO defines adolescent-friendly interventions as those that are acceptable. So adolescents are willing to obtain the available services. They're equitable and that they're not just available to certain subgroups. They're appropriate in that they provide the right health system services, and they're effective in that they're provided in a way that they make a positive contribution to health. And so I think these principles, while quite logical, I think much remains to be learned about how they can be successfully translated to practice. So now I'll just transition to talk about our work in Lima, Peru. So there are about 70,000 people living with HIV in Lima, or in Peru, with the highest concentration of HIV in Lima, the nation's capital. While the majority of HIV infections in younger adolescents are perinatal infections. About 60% of all new cases in Peru occur among young men who have sex with men and transgender women, in whom the prevalence ranges from about 10 to up to 30% among transgender women. Antiretroviral therapy has been available free of charge since 2004, but it is largely centralized, although recently, just in the last couple of years, there have been huge efforts to start to decentralize HIV care out of the hospitals and into the primary health clinics. In 2018, the Ministry of Health reported about 7,100 prevalent cases of HIV in adolescents 10 to 19 years old. And while this number is relatively small compared to many settings, I think one consequence of this low HIV burden is that within programs, there are often very few resources devoted to support this group, very little data on outcomes and program performance, and at least in Peru, very few resources that are dedicated to interventions. And our work in this area started in 2013 and was really motivated by Dr. Lenka Kolovic, who you see here. She's a pediatric infectious disease specialist and ID chief at the National Children's Hospital. She approached Socios en Salud asking for intervention support for the adolescents in her service, was feeling very frustrated because she felt that many of her adolescent patients were struggling with adherence, but other than hospitalization to stabilize adherence, she really felt like she had no interventions to offer them. So our work started off very modestly with a small internal grant from Harvard. Our goal was to provide a bit of direct support and to also understand and document the problem with some basic qualitative and quantitative research. So we conducted qualitative interviews with caregivers and providers, a chart review among adolescents currently in care, and we conducted a series of social support groups for children 10 to 19 that we also recorded and used as a qualitative data source. So the social support groups were led by women who were living with HIV and had previously participated in support group themselves and been trained in the support group facilitation process. Adolescents were grouped by age, and the intention was for the groups to be participant-led. And we also collected some very basic information on adherence, sexual activity, and other health-related behaviors, which we implemented using a tablet and self-interview platform so the adolescents could either read or listen to the questions and respond anonymously. So I'll just present a few of these findings here. When we looked at the viral load and CD4 trajectories of the adolescents that were currently in care, there were 121 of them. We found substantial decreases in these indicators during mid to late adolescence. So you can see at age 13, about 85% were virally suppressed, and this went down to 71% by the age of 18. And you see a similar pattern for declines in CD4 count, which was also reflected in self-reported adherence, which I don't show here. This is a graphic, I know it's probably small for you all, of some of our findings from the qualitative work related to factors that influenced adherence at the patient, family, and facility levels. And I'll just mention that while I wouldn't do it differently, using the support groups as a qualitative data source was really challenging because, the facilitators of the group were appropriately managing the groups as a support group rather than as a focus group. So as we read over the transcripts, we were often wishing there had been sort of additional probing or follow-up, but this was really our solution to really wanting to provide some sort of direct service in the context of this research. So in this graphic, I just want to point out two factors that appear to contribute importantly to adherence and that influenced our subsequent projects. The first was access to accurate information on HIV treatment. And the second was factors related to caregiver support. So negative or inadequate caregiver support was negatively associated with adherence, while its positive adult support contributed, facilitated adherence. And here is just one illustrative quote from an adolescent who felt that the messages that he received related to pill taking and CD4 count helped him take his medicines consistently. So she said that I must take my pills on time, and if I don't, then my CD4 level won't rise. I have to get up early and keep at it, since if I stop taking them for a day, then that would be the same as if you were to lose 10% of your CD4 counts. She told me something like that. And I should mention that all names have been changed from the qualitative quotes. So just in general, we were seeing a trend that many adolescents did not have a firm grasp on such concepts as viral load, CD4 count, and adherence, and how those things related to one another. And so this idea of access to information seemed like a very solvable, or I won't say solvable, I'll say addressable problem, and inspired the team to make a music video. So at the time, there was a volunteer with Socios and Salud named Alex Winnett, who convened a team of just incredibly talented artists, students, including the Columbia National Freestyle Rap Champion, to draft the lyrics and then come to Peru to film it. And the objective of the video was to highlight the importance of daily adherence and clarify the relationship between CD4 cell count, viral load, and adherence. And I'm going to show just a quick clip of that.
Mi hermano, no sé, lo que sé es que lo malo no existe después del ARB.
So to formally evaluate the potential for a tool like this, we asked a small group of 27 adolescents to watch the video and then complete a pre and post test and also to participate in a focus group. So they could watch the video as many times as they wanted in between the pre and post test. So in the post test results, we saw modest increases in the number of correct responses to questions that most directly aligned with the content of the video. I think the overall number with correct responses is still quite low. And I should also say in full disclosure that I have cherry picked the questions here for which we saw the biggest difference. But the qualitative data also supported our quantitative findings. So this is a quote from one young person who said, before the video, I thought that CD4 was, for example, the virus that was in our body and that the viral load was a good one. And the researcher said, and now from the video, what did you understand? And the adolescent says that the CD4 is our cells that protect our body, and the viral load, the virus that is acting. The qualitative data also revealed sort of just the strong potential of this medium as a tool for increasing knowledge and improving adherence. So it was described as not boring as compared to brochures or talks. The young musicians were viewed as credible and also comforting messengers. The recognizable scenes in Lima contributed to the relevance of the video's content. You know, several adolescents remarked that because there were scenes of Lima, they knew that the messages in the video were not just, you know, things that were relevant to some other setting, but they really felt like it was directed towards them. I think a couple things that came up that we had not necessarily anticipated was that for a number of adolescents, the video made them feel less alone and also motivated them to take responsibility for their care. So this was one quote from a male in the study. He says, "It all depends on us that we take care of ourselves and improve our health. It depends on whether we take care of ourselves, take our medicine when we should. This is what it teaches. What I got out of it the most is that." And then a number of adolescents also expressed that they could show the video in school or to friends or family members as a way of reducing stigma, and were eager for more videos that could be used for that purpose. So a related follow-up activity that we did that also just sort of reinforced sort of the power of kind of social media and this genre of communication was a project that we did just as a short activity during COVID to sort of keep a group of adolescents we were working with engaged. We asked them to create memes that would transmit destigmatizing messages or debunk a common myth about people living with HIV. And here's just a selection of them. So on the left, you see Joey saying, "You have HIV," and she says, "Yes, but that does not stop me from being who I am or who I'll be in the future." The next one, sort of in the top middle, says, "I have HIV, but I won't give it to you if you hug me or kiss me." On the top right, it says, when they think that by being HIV positive, they can't come near me or talk to me. How ridiculous. And then this last one, which I particularly like, which takes advantage of a social media sort of icon in Peru called the Little Chicken, who has this catchphrase of "it had to be said, and so it was said." So this one says, "Kissing will not transmit HIV. It had to be said, and so it was said." So based on data from these preliminary experiences, we were recently, just this year, able to secure an R01 from the Fogarty International Center to explore the feasibility of working with social media influencers to transmit messages aiming to reduce HIV-related stigmas and other stigmas in Peru. So this is just sort of an overview of what this project looks like. So it starts with a stigma mapping exercise in which we conduct some focus groups with young people as well as HIV advocates and organizers to understand from their perspective what they feel like the key messages are that needs to be transmitted, what the most important types of intersectional stigmas are, and what they would like to see change as a result of a stigma reduction intervention. We're also working with a social media organization, a marketing company in Peru, to recruit influencers to work on this project with us. Then in the next phase, based on our qualitative work, we're working with another company to develop some social media content based on these messages. And we have sort of an advisory board who, once we have the content developed, will review it for us. And then the third phase is really the evaluation phase. So the first step is that we'll do a social marketing simulation, which is basically sort of a randomized trial that takes place online where young people are randomized to a social media reel that either contains our content or does not. And so they answer some questions related to HIV stigma before being exposed to the reel and after, to see if exposure to the reel changes sort of their ideas about people living with HIV. And that's really aiming to test our process of, are we able to effectively translate the knowledge from the mapping exercise to content that has the potential to change ideas. The next step is a dissemination exercise in which we'll ask the influencers that we recruit to disseminate this content over about a 3-month period at regular interviews and intervals, and we'll be tracking things like virality, how many people have seen the posts, the sentiments. So are the responses to the posts typically positive or negative? There's a whole sort of host of social media metrics that can be tracked. And then simultaneous to this, we are actually conducting a trial in which a group of 150 adolescents will either be given a list of sort of health-related social media handles that have nothing to do with HIV, that list, plus our DMA, I should have mentioned that the name of our project is DMA, which is Tell Me in Peru. So they'll be given the list of health-related resources and the DMA account overview. And then the third group will be given the list of health resources, the DMA profile, as well as a list of influencers that align with their interests who are participating in this project and expected to be disseminating over the course of that 3-month period. And we'll track changes in perceived stigma in those 3 groups. One sort of ethically kind of sticky point that's come up as we've been planning this study is the different expectations, how to balance the different expectations for incentives for participation in focus groups. So typically we provide about 50 Peruvian soles, which is about $12 for participation in a 1-hour group. The expectations for influencers is 10 times that. Which is obviously a huge discrepancy. And I think, none of us feel comfortable in sort of attaching greater financial value to certain people's perspectives over others. But we also acknowledge that kind of understanding how to work with these influencers is incredibly important. So I think that's something that we're continuing to talk about with our youth advisory board and continuing to think about. But if other people have encountered that, I'd be interested to hear. Okay, now I'm just going to switch gears to talk about the other major area of focus for our team, which has been the transition into adult HIV care. And in Peru, this occurs either because an adolescent ages out of their pediatric care provider, which typically happens at around 18 in Peru, or because the adolescent was newly diagnosed with HIV and is transitioning into an adult care facility for the first time. Pregnant adolescents also transition to adult care regardless of age. And so in the context of HIV and many other chronic diseases, this transition period is often marked by episodic care with missed clinic visits and lower adherence rates. And some of the challenges associated with this period include the loss of the pediatric care provider, which for adolescents living with HIV since infancy is often a really critically important life relationship. There are also additional logistics barriers related to health insurance and other administrative procedures. And in many places, the adult care setting is just sort of less nurturing and really a stark contrast to the pediatric care environment. And so the goal of the project I'll describe next, which was funded through an R21 through the NIH, was to document the transition outcomes under routine care in Peru, and then also to pilot an accompaniment intervention to support adolescents during the transition phase. And I'll just add that the existing standard of care for adolescents transitioning to adult care in Peru really just includes a referral to enroll in public health insurance, and then also a multidisciplinary case conference with a nurse, ID specialist, psychologist, and social worker prior to transition. So a report is written up and then given to the adolescent, which then they're expected to bring to their first appointment in the adults clinic. So this graph shows retention and viral suppression within the first 3 years of care. So the blue colors indicate the proportion retained in care for the entire follow-up period, with different shades of blue differentiating between having a suppressed viral load, no viral load, or unsuppressed viral load. The green represents those who were not retained. So as you can see at each time point, the frequency of becoming lost increases substantially, while the frequency of retention with viral suppression is actually quite low, ranging from just over 40% at 12 months to just over 20% at 36 months. And I should say that this particular slide is among adolescents who were newly diagnosed with HIV during this time period. But if you look at adolescents who transitioned from pediatric care, the numbers are almost identical. So this was an overview of our intervention, which was nicknamed Paseo, which really not only aimed to just support HIV care, but also to fortify some of those building blocks for health that we talked about earlier. So each participant was matched to an entry-level health worker with a technical health degree called the health promoter. This person accompanied them to their clinic visits, helped navigate enrollment in public insurance, conducted monthly meetings with the adolescent and, where possible, the caregiver in order to review adherence, upcoming appointments, transition goals, and also to help resolve any acute social or clinical needs. Adolescents convened twice monthly for social support groups and education sessions, and were screened for depression and referred for care as needed. Adolescents who were struggling with adherence were eligible to receive home visits for DOT from a government community health worker. But I should say, I think we should actually really, our group needs to stop calling this DOT, because the visits were really much less about the direct observation of treatment and much more about providing support and really offering a forum for practicing good adherence routines. We had a youth advisory board that we convened as part of this project, which consisted of a group of diverse group of 10 young people living with HIV. So in this pilot study, we enrolled 30 adolescents transitioning to adult care. So we enrolled them at the time of their transition. So either at the time of their last visit at the pediatric facility, or upon diagnosis where possible among newly diagnosed adolescents. They ranged in age from 15 to 21 years. And they really encapsulated the range of transition experiences that have happened, that you see in Lima. So from the pediatric to the adult care provider, new diagnoses, transitioning within the same overall facility, transitions to a different facility. They included pregnant women, as well as about 5 or 6 individuals who actually had been lost from care during the transition period, and that we were able to re-enroll. So this is just sort of a snapshot of some of the participant characteristics. And I think the main takeaway here is just like the amount of things that the adolescents were dealing with that had that were not their HIV. So 5 were Venezuelan migrants. Only 63% had a living parent. 70% had suffered from a traumatic life event, with 40% reporting a history of past sexual abuse or assault. 4 individuals were pregnant. 4 were actually living on the street at the time when they were enrolled in the project. And a large majority were experiencing depression, although in most cases they were mild or moderate cases of depression. And so of the 36 adolescents that we invited to participate, 30 accepted. 4 people who did not accept were individuals who had stopped taking treatment and were pre-contemplative about sort of reinitiating, and then 2 refused due to time constraints. 8 adolescents received and completed DOT. 90% attended at least one social support session in person, and then 93% participated in a virtual session. I won't talk about this now, but the pandemic started smack in the middle of, we were just sort of finishing enrollment, which took place over 6 months when the pandemic started. So the Paseo experience differed for participants based on when they had enrolled. And all adolescents were retained at 12 months. So I should have mentioned that the intervention was a 9-month intervention. So it was 6 months of sort of intensive support and then a 3-month kind of taper down phase. And we followed adolescents for 12 months. And so all were retained in care at 12 months. We also measured a whole host of psychosocial and transition indicators, including stress, self-efficacy, social support, and adherence. Here you can see the within-person changes from baseline until the end of the intervention for transition readiness, which we measured using like 2 different scales that you see here, got transition and am I on track? So the gray box indicates the 25th to the 75th percentile. And again, these are changes within the individual person. So you can see that in all cases, the bottom of the gray box is above 0, suggesting that 75% of individuals experienced a positive change in transition readiness. And generally, we saw statistically significant improvements across all metrics, and these tended to be sustained at that 12-month mark, which was 3 months post-intervention, which was our last data collection time point. We were unable to look at viral load suppression just because the pandemic, the National HIV program was not routinely running viral loads during the pandemic. And this is probably sacrilegious for an epidemiologist, but even though we were happy to see the changes in those quantitative metrics, I don't find those data particularly compelling in the sense that it's hard to truly understand the implications of a 2-point increase in social support or a 3-point decrease in stress. In contrast, I think the qualitative work is quite informative and really demonstrated the potential impact of this intervention. So one adolescent said, "I feel safe and confident and able to complete the administrative processes and treatment on my own." Another said, "Before Paseo, I just stayed in my living room, but then I met new people and felt free to talk about things and not be judged like any topic. They don't judge you when you said something, whether it was right or wrong." Or they didn't judge you when you said something, whether it was right or wrong. In my case, sometimes I didn't take my medication because I forgot to, or I lost track of time. So then the lady from Paseo calls on WhatsApp. I knew that at 8 p.m. I had to take my pill. So now, like all the other girls and guys here, I think it's one's own responsibility. So that was an adolescent that was receiving DOT. And then the last adolescent says, "I'm very thankful because my health promoter was there for me, even though I refused to go back on treatment. She was there with me to this day, and now I'm undetectable, and it's all because of her. She was there for me not only as a worker, but as a friend." So I think, some of the lessons, these were just some of our kind of unexpected lessons learned and challenges. So one is that, we had an extremely diverse group of individuals, and I think there is a tendency to really call out the differences between adolescents who are newly infected with HIV and those that have been living with HIV since birth. And without a doubt, there are different issues that are specific to those 2 groups. But I think in general, our experience was that the similarities between these groups were quite powerful in the sense of isolation and the struggles with adherence and stigma and uncertainty about the future. And that actually in the context of an individualized intervention, particularly where you're sort of meeting each adolescent where they're at, I think these differences become less important in terms of, like we, in our social support groups, we integrated them fully. And I think that was a very positive thing overall. We do recognize that we need to further tailor this intervention to young transgender women. We only enrolled one in our study. And I'm happy to talk about the reasons that might be during the Q&A, but I think that's an area of work for us if we really want this to be an equitable intervention. I think staff burnout was a huge issue. I just think the emotional toll that supporting these adolescents took on the staff was unexpected. And I think in our future work, we're really trying to build in mental health supports for the health promoters. And then I think another challenge is just the cases of extreme need that will never be a 9-month intervention will never be enough. And so there need to be mechanisms of support for the relatively small subgroup of adolescents that are going to need a longer term support. So I just have a couple more slides, but I did want to talk about, we were clearly very excited about how our pilot went. And as we started to scale up and think about, a larger scale evaluation, we started to think a lot about study design. And we sort of contemplated 4 of them. The first was a single arm trial with historical controls. And that was something, this was something I'll just sort of, this is a bit of a spoiler alert, but this was really our first go-to for a number of reasons. I think the benefits of this, the potential benefits of this intervention, just from a sort of a human perspective, were very clear, even if there was not necessarily data support to support a long-term benefit on HIV outcomes. And so for us, a single arm trial was a great option because it allowed us to potentially enroll as many people as possible in the intervention and compare them to what really was the standard of care without, thinking about, like in trials, you always have to think about the fact that just enrolling in a study can raise the standard of care. And additionally, another real consideration is the idea that in a trial, you're sort of letting the adolescent know that there are 2 possibilities. One is this really comprehensive support, and the other is, potentially nothing, and just kind of what sort of the psychological harm that can do. So that was what we first opted for. Some of the other options that we considered were just, a conventional randomized trial. We also considered a conventional trial in which we raised the standard of care in the control group. So maybe we would provide some of these things, but not others. But then I think interpreting that becomes, from a Ministry of Health perspective, becomes really complicated. Because it doesn't tell you about the benefit of the intervention with regard to what the programmatic standard is. And then the last option we considered was a randomized trial in which you crossed over, in which individuals from the control group who experienced a bad outcome could cross over to the intervention group. So we submitted an R01 with our single arm trial with historical controls, and it was not embraced. So this is a comment from one of the reviewers who said, because the Youth Advisory Board said that a control group was undesirable because the intervention will be beneficial is a weak argument. Neither they nor the investigators know that, and if they did, there would be no need for a study. And I really appreciate the comment. I understand the spirit of this, but I do think trials are not always the best method. We know that being in a trial alone raises the standard of care. And we also know that if your control group feels alienated, aside from the potential harm to the participant in terms of how they perceive researchers and the healthcare system, if controls draw from your study because they're unhappy, your study could also be biased. Your randomized trial could also be biased. So I do think as a research community, we can't be afraid to embrace the idea that there are other study designs that in some circumstances can yield equally good and perhaps not better data than trials. So we went back to the Youth Advisory Board with this feedback and spent a meeting reviewing the potential pros and cons of each study design and how they might be received to the adolescent, as well as the quality of the evidence that it would produce. And in the end, we opted And, you know, among the choices were to stick to our original decision and just, you know, try to make a stronger case. But in the end, the Youth Advisory Board really felt that sort of the crossover design where you have a trial, but that members of the control arm can cross over as needed was the best option. So we did end up resubmitting the R01 with that, and it was recently funded. So we will be testing this intervention at a larger scale. I am about to wrap up, but I just wanted to mention a few final things. You know, one thing, another sort of epidemiologic argument that has come up in reviews is this idea of contamination, or the idea that your control group could be impacted by the intervention. So either through contact with an individual in the intervention arm or through incidental contact with social media. This comment comes up over and over again. And to me, they're kind of funny, because on one hand, I understand that as a researcher, there is a methodological concern there. But when you put on your public health practitioner hat, an intervention that manages to influence others indirectly or unintentionally would be highly desirable. And so for me, I think it's much more about understanding if contamination occurs and how, rather than trying to come up with designs that reduce this idea of contamination. So I just want to be very clear on kind of what the timeline of this work is, because I've certainly highlighted the successes. This is a timeline of all the grants that we submitted to support this work. So the spots in green are the grants that we submitted to support sort of the DMA project related to social media and the rap video in that line. The squares in blue represent sort of the transition to adult care adherence support line of grants. So the light ones are the ones that were not funded. The dark ones are the ones that were funded. So this is just to highlight that, you know, we have had plenty of failures along the way in trying to grow this work. And certainly I do not think that research is the fastest way to grow a care delivery platform, but it may be one avenue to do so. So just to close, I think some of the essential elements to this work really have just been the incredibly committed multidisciplinary team. In Peru, I think the mixed methods have really been critical, and oftentimes it really is the qualitative work that I think has been most compelling. Our youth advisory board really was essential and continues to be essential in guiding all of our work in sort of keeping us focused on the right things. And the last piece of advice I'll give is just sort of anticipating the next steps, and as you're starting a new endeavor, thinking about what you might need to do to position yourself for the next step, I think is really important and has been helpful to our team. So I will end there. I know I went a little long, but thank you for your attention.
Thanks so much, Molly. That was an amazing presentation of
a long trajectory of work. It's really incredible how much you've stuck in there with it, despite the challenges in funding and other things. Joy has a question. I wanted to just open up with one quick, if you don't mind. You were mentioning about that traditionally there's a distinction made between, or concerns made about, different needs of adolescents who contracted HIV when they were younger versus ones who recently get it as they become more socially and otherwise active. Did you find, you said that that you actually found that there wasn't much of a difference in terms of the intervention. Did you find that there were there any differences? Was there any sense that future iterations could tailor the intervention to those different groups, or did they really kind of just aggregate more than you expected?
You know, I think they definitely did aggregate more than we expected. I do think there are some clear differences. I mean, at least in Peru, adolescents who have been living with HIV since birth are tend to be much more poor. So they have fewer financial resources, and so tend to not be able to explore, you know, like higher education opportunities. I think also, and we explicitly asked the adolescents this in our focus groups, did you like this integration? Did you feel like and it was overwhelmingly yes, but there were some young gay men who thought that it would be useful to have like additional sort of extra sessions in which they could talk about issues that sort of were specific to their new diagnosis and personal situation. So that is something that we'll make available in this iteration for sure.
Great, thanks. And I don't know, Molly, if you can see the question or I can just read it.
Oh, I can see it.
Great.
Oh, sorry, I'm just seeing, oh, sorry, I was looking in the chat, so I was looking at accreditation. Okay. Yeah, so Joya is asking a question related to the similarities between this work and what you find with the HIV community health worker program in Rwanda. I mean, I think this work has been modeled off of the very like long history of accompaniment that has been part of PIH from the very beginning. And so, you know, in very early on in the Rwanda project, we sort of collected some observational data among adolescents, or not adolescents, actually adults who were receiving HIV care in the context of PIH that was providing sort of this accompaniment model versus another rural area of the country that had a very strong HIV program, but did not necessarily include sort of the daily social support, nutritional support, et cetera. And what we saw in Rwanda were actually huge differences, not only in terms of like HIV outcomes, but, you know, much lower rates of depression at the end of 1 year. So at the beginning of treatment, the groups looked very similar in terms of a lot of the psychosocial indicators, so quality of life, depression. But then at the end of that year, the patients who were receiving accompaniment tended to have much like higher scores on quality of life scales, lower rates of depression, et cetera. And so I think, you know, to that vein, like the trends are overall very similar and really intuitive. I mean, I think.
Great. Any other questions for Molly?
Molly, I have a question. You mentioned this when you talked about your qualitative results and your, you know, how helpful they were. Like, how do you balance as an epidemiologist the, you know, the richness of the qualitative data? Because I was noting that you do a lot of qualitative work to inform your quantitative work. How do you balance that in your own kind of approach to the questions you're trying to answer?
Yeah, it's an interesting question. I mean, I think my instinct is to always, like, my focus is always the quantitative, but then without fail with this work, I am always more moved by the qualitative, and I just have become more convinced than ever of the importance of sort of elevating and valuing the voices of the participants as part of this work, because it's very clear to me that while the messages are completely consistent, one is much more powerful than the other, in my opinion. And you know, we haven't actually been able to properly integrate our mixed methods where we sort of do one and that informs the other. Just for time, we tend to do these things at the same time. But that is something that I'd like to consider for the future.
I mean, I thought it was interesting because reviewer 3, you know, in your R01 is basically dismissing the, I mean, I understand, and you mentioned how you tried to grapple with this, but your youth advisory board, who, you know, I presume were insightful enough to give you the ideas around the rap video that was really impactful, like they're saying to you, like, we don't think this is the way to go, but the NIH reviewers are like, well, you have to do something differently anyway. You know, it's just, I mean, it's not ironic, it's kind of just par for the course, but it seems problematic.
Yeah, well, there's another layer of that, which is that the NIH funded R21 mechanism that generated all of this data required us to have a youth advisory board. So it's something we would have done anyway. But, you know, I mean, I think that's our job as sort of reviewers to sort of challenge that culture if we're in study section or reviewing a paper. You know, I I am very much an epidemiologist at heart, but it's very clear to me that sort of we've lost the forest through the trees, I think, on some of these issues.
Molly, there's another question in the Q&A. Can you see it from Chase?
But why don't we read it, Joe? Just
Okay, sure.
I can,
Chase asked, how interlinked is the stigma of HIV and the stigma of gender sexual orientation minorities in this setting, and are both stigmas addressed in the DMA project?
Hi, Chase. It's good to see you. Yeah, they're incredibly, and it's a great question. They're incredibly linked. And, you know, one of our main, I think we're definitely going to have to address them together in all of the DMA content. The way we've sort of structured it is that we're going to, in our focus groups, we have representation from many of the affected groups in Peru, including sexual and gender minorities. And so we're really asking them what intersectional stigmas they think are most important. I think absolutely stigma against MSM and transgender women is going to be incredibly important to address. I also think poverty is going to be another important intersectional stigma that I don't think you hear as much discussion about, but it's a great question and something that we are thinking a lot about.
Great, and if there's anyone else with a question, please just feel free to either type it in or unmute.
I have a quick question, Molly. Could you just, I know there's just a minute, but these interventions you've done are really incredible. Could you just talk very briefly about how scalable you think they could be within Peru and in other settings?
Yeah, I mean, I think the thing that I love about the social media intervention is I think that's, you know, incredibly scalable. I think the real question there is like, what do you have to do to motivate influencers to participate, and sort of what does that look like? I think we very much believe and would like to believe that an intervention such as Paseo is something that the Ministry of Health would be willing to scale. You know, we've included the HIV program has been very involved in all of our work. You know, I think you know, several members of the HIV strategy have said that they think there's an incredibly important role for Paseo, but a lot of it comes down to cost. And so we do have a costing element in our future study. But I also just, I mean, I think it has to be scalable is the thing, because I think, you know, the idea, like, there are so many needs in this population that you really have to address them all at the same time. And I think there are ways that the HIV program has a very strong peer supporter network. So these are peers that are living with HIV that work in the health centers. And I think if there could be additional investment in expanding this cadre of health workers, that would be one way of sort of integrating the Paseo intervention into the program. But I just think it has to be scalable.
Well, thanks so much, Molly. We're out of time, but it's amazing work, and that was a great presentation. Thanks so much for sharing it with us.
Thanks so much for the invitation. Thanks so much for coming, everyone.